of survival, both progression-free and overall, for a multitude of pathologies, breast cancer, prostate cancer, rectal cancer, etc., by ablating all known disease in a situation like this, oligometastatic. So let's address that first. Now it's going to be complicated by accord involvement, so let's do this, and then from a learning point of view. So what we need to know in this case is that your standard radiation, first of all, the patient needs to be sent to a radiation doctor, right? Pain or not, this patient must be seen by a radiation doctor. Overall survival difference is on the line. When they are seen by a radiation doctor, they must be treated with ablative techniques. And you guys all know what the difference is. When a woman has her breast irradiated, the goal is for 99% of those cells to live, right? You're not trying to destroy the cells. You're not trying to destroy that breast. That's radiotherapy. It's in little tiny pieces day after day, right? Sometimes when a radiation doctor is treating someone, they're trying to ablate the target, destroy it, like a brain metastases. So 3-4 millimeter target, we're not trying to have anything inside that target survive. We want it all to die. We're only targeting the problem. So when you look at this spine, it's a little somewhere in between. We need to use ablative doses. We need to sterilize that colony because that was what was done in the research that showed an extension of life. So if your radiation doctor isn't involved in the case immediately, you lose that opportunity. And if they just use palliative techniques from the last 30 years, you've lost that opportunity. It may help. We don't have that research study. What we do know is if your radiation oncologist gets involved early and uses ablative, aggressive doses, sometimes called radiosurgery, if they use those types of doses in this patient, they should be able to make a very significant impact on survival. Now, to complicate that is your astute observation that there may be cord involvement. You cannot use destructive doses in the spinal cord, obviously. So this is a case that would actually, in a real hospital, this case would go right to tumor board because the radiation doctor and radiologist are going to have to hash this out. Is this cord involvement or epidural space involvement, in which case the radiation doctor has to back off a little bit? And it may be that they have to give traditional palliative doses to prevent a neurologic event. Or is this an opportunity to do oligometastatic stereotactic ablative therapy, in which case we may be able to assist the medical oncologist in the extension of life?
And just to break that down just a little bit more, you know, when I'm meeting that patient with this type of stage 4 disease, you know, I just want to kind of relate it to them. There's that commercial on TV with the woman walking around the kitchen. They said, I have stage 4 disease, and she's on Ibrance and Femara. So those are the drugs that we're talking about, just to give you, so you're a little bit more familiar, and that is what we call oral chemotherapy. Okay?
Yeah, I was going to add one other thing, because I think that's why I like these tumor board. I mean, right. Even this kind of setup tumor board is, he's exactly right. The first question we should always ask ourselves, even if it's stage 4, is how do I cure this person? Exactly. Is there a curable option? Mm-hmm. And even just you kind of saw where I was saying, oh, well, we're going to do this, and he's kind of readdressing us to say, hey, think about it. And that should be the first thing. The second thing would be, as far as the front line, and I think clinical trials is up there too, and I don't know how much time we have, but the frontline therapy is pretty much standardized for most people now, which is a CDK4/6, something like palbociclib or ribociclib or abemaciclib, plus an aromatase inhibitor like Femara, which is the one used in the trials. For the second line, if she relapses, if we cannot cure this person and she relapses, then I think clinical and trial enrollment becomes very critical and very crucial. At Wellstar, Northwest Georgia Oncology, we have 2 different clinical trials looking at fulvestrant, and then they get randomized in a 1-to-1 fashion to either fulvestrant or something called venetoclax, which is a BCL2 inhibitor, which is FDA approved in other different diseases. And we also have another one called the Morpheus trial, which is looking at fulvestrant, which is the standard of care, adding in immunotherapy plus or minus either an AKT inhibitor or an HDAC inhibitor. But there are clinical trial options for these women really in the second line that should be standard. I'm sure Emory has different ones that she's going to talk about too.
I'm in complete agreement with that as well. And we do, in fact, have also clinical trials at Emory that address the question of what happens at the time of relapse in women who have relapsed on a CDK4 inhibitor plus an aromatase inhibitor. And we have similar trials to what Dr. French was talking about. One trial is actually the combination of an immunotherapy with fulvestrant and perhaps with a CDK4/6 inhibitor as well, if the patient had previously not had a CDK4/6 inhibitor. The other trial that we have is actually utilizing another targeted approach. It's a target towards 2 other pathways that have been proven to be involved in cell growth, cancer cell growth, proliferation, and metastases, and that is the PI3 kinase and mTOR inhibitor pathways. So it's a combination of actually a target that targets both the PI3 kinase pathway and the mTOR inhibitor pathway, along with Faslodex as well. So we have that option.
Well, great. We're going to move on to the next case, and we'll take a few questions at the end. Next case, she's 56 years old, most common type of breast cancer as well, invasive ductal carcinoma. She's what we call triple negative, no estrogen, no progesterone, and no HER2 new. She was diagnosed 2 years ago. At that time, the facility that she was treated at, they did not do genetic testing. At that time, she was stage 3. Tumor was significant. Had fixed nodes in the axilla. Chemotherapy was given prior to surgery, which is a good thing. She had adriamycin, Cytoxan, and Taxol. She opted to have, although she had disease on only one part of her breast, she chose to have bilateral mastectomies, and she had all the lymph nodes removed. And the initial tumor size was about 4 centimeters. It shrank down to 1. And she had 2 out of 18 lymph nodes after chemotherapy. Her provider offered her Xeloda, which is often done with triple-negative breast cancer after neoadjuvant chemotherapy and residual disease is found. So she comes back in 2 years, has some abdominal swelling, and she has a metastatic workup. And on the right to you guys, that's actually the heart in the center. At the bottom there's a little round lesion right of the spine, and that is a pulmonary lesion. On the next slide to the left, the figure to your right, that's your liver. And the dark gray areas, that's liver metastasis. So we're going to talk about what we would offer her. You want to get started, Dr. Bhave?
Sure. I think Dr. French is supposed to go on this
one.
one.
He's supposed to go first.
No.
I didn't want to. It's easier if you go first, right?
All right. So first of all, unfortunately, this is a more common situation that we'd like to see with triple-negative breast cancers. Triple-negative breast cancers do unfortunately account for a smaller subset of women, but they tend to have more aggressive disease, and oftentimes we do see recurrence after we've attempted curative intent therapy. The first thing that I would recommend for a patient like her is, again, to get a biopsy of a metastatic site, not so much to prove what the receptors are, but also to send for the tumor for genomic sequencing to identify potentially any targeted options available for the patient. Also to send the tumor for certain protein expression in the immune cells called PD-L1, for which we now have an FDA-approved immunotherapy to offer women that are PD-L1 positive in the metastatic setting for triple-negative breast cancer. So that's the first thing that I would do. There's a number of genomic sequencing modalities that can be used, Foundation One, Tempus, Caris, so a lot of different companies that are offering genomic sequencing. It makes it very easy for patients and potentially, again, offers them targeted therapies or clinical trial options in the future down the road. In terms of our current standard of care, if a woman does have PD-L1 positive triple-negative breast cancer, then we can actually offer them immunotherapy, which is an exciting new therapy for breast cancer patients that was previously not approved. So it's a combination of atezolizumab, again, which is an immunotherapy in combination with chemotherapy that has improved both how long we can control a woman's cancer and also overall survival in women that are PD-L1 positive. So that is something that I would strongly consider in this woman if she does have a PD-L1 positive breast cancer. If it's PD-L1 negative, then we do start talking about standard of care chemotherapy options versus potentially clinical trial if we are able to identify a matched clinical trial or a clinical trial that the patient would be eligible for.
Oh, geez, that's a tough one. The other thing that if she hasn't had genetics already, she needs genetic testing. You're looking for, again, as we're going to talk, you'll probably talk about kind of the BRCA1 and 2 mutations, because that does, you might not start with these drugs looking at olaparib or some of these BRCA inhibitors or these drugs that work on these pathways. But the name of the game at this point is to try to open up your armament to say, how many options can I have in my back pocket when I need them. If you look at the data with the Impassion 130 trial, that was with the addition of the atezolizumab, it does increase progression-free survival, and at the last, I think it was AACR update, they actually had an overall survival update. So it does add more toxicities to the regimen now, because now you're adding immunotherapy, but with the survival advantage, it is FDA approved, and that's probably the new standard of care that is as of just in the last 12 months or so. It's actually probably less than 6 months ago. You want to talk about that?
I do.
Yeah.
Thank you. Yeah, so as Dr. French said, this patient clearly meets the criteria for genetic testing, because any woman diagnosed with triple-negative breast cancer under 60, regardless of her family history, her stage, anything else, is recommended to have genetic counseling and testing. And given that we brought up genomic tumor sequencing, I just want to make sure everybody understands that we've talked a lot about genomics and genetics already today, and a lot of that discussion is around tumor genetics and genomics. What I do in my clinic is different. We're testing inherited, your DNA that a person is born with. You can do that type of genetic testing on a person with cancer, without cancer. It's not dependent on the tumor. It's talking about your genes that you were born with and whether a person is predisposed to certain types of cancer due to something that they inherited almost always from one of their parents. So sometimes in these talks and even in papers or articles online, it can get confusing to know whether they're talking about BRCA or a gene that's isolated in a tumor or whether it's inherited. So you always want to make sure if you've had a tumor genomic test, that doesn't rule out the need for inherited mutation testing, because a small percentage of people could have an inherited BRCA mutation that does not show up in their tumor testing. So you always want to make sure if your doctors are talking to you about BRCA, you've had both types of testing to completely, like Dr. French said, make sure that all your eligibility is known, because usually the indications are for either tumor or germline or both. And germline means inherited. That's, if you see that word, that's talking about inherited DNA, versus somatic or tumor are talking about mutations in a tumor.
Okay, so one of the reasons that you do tumor board with multidisciplinary approaches is that sometimes you read the body language and the tone of voice off your colleagues. Did you guys hear how excited they are? This gene and that gene, we'll do immunotherapy and new standard of care. From the radiation point of view, they've got something to offer, right? Now you might say, wait a minute, didn't you just say on the last patient a few Mets and only a couple of organs and you should go to the races with the radiation? Yeah, those were little Mets. Those were little Mets. This liver, even if you called that two, they're huge and they move every time the patient breathes, right? So that's why you can't do medicine just by algorithm. You have to have some common sense in there, and you have to have some teamwork. This is just not a radiation case at the moment. They've got things they can offer that are going to extend life, and they may shrink targets up. And maybe you invite a radiation oncologist to review the case again down the line. But at the moment, this is a systemic therapy case.
I just want to add one other comment in terms of the gene sequencing, is that I think there is a lot of education going on both in the academic world, where not all triple-negative breast cancer is the same. And so I think with Foundation 1 testing, is I think eventually what we're going to find is that triple-negative breast cancer is going to be kind of what we see in lung cancer, is that we're looking for a driver mutation, where we used to think, oh, you have small cell or non-small cell lung cancer. Well, now non-small cell lung cancer is broken out of two different parts, and now we're actually saying, oh, well, you have a MET mutated non-small cell lung cancer. I know it's a little bit complicated, but triple-negative breast cancer is not all one disease. And I think there are a lot of clinical trials looking for specific targets to say, okay, you have triple-negative, but what's driving it? And whether that's something to say, oh, this is an androgen-positive breast cancer, so we're using therapies like you would use in prostate, or you're using pills to target that specific mutation is very important in our triple-negative cases.
I agree. I think that's a really good point, and I do think that a lot of the trials nowadays that are focused on triple negative are looking at the up to 6 subsets of triple negative breast cancer and how to best target each of those as perhaps different type, as Dr. French mentioned, different drivers for each subset of triple negative. We do also have clinical trials available for triple negative breast cancer at Emory, and I'm sure Wellstar does as well. The one that is coming to Emory soon is actually the use of a PARP inhibitor, which has been currently FDA approved only for women that have the BRCA germline mutation. There is a trial looking at the combination of a PARP inhibitor with another type of targeted therapy, also an oral drug, that perhaps would actually, that works together to get to better control triple negative breast cancer. And that is actually offered for all triple negative breast cancer patients who have progressed on chemotherapy, irregardless of whether they have a BRCA mutation. So again, offers an oral targeted therapy to more women with this clinical trial.
And then the last, do I have time?
Yeah.
The last thing I wanted to say, because this is a community forum, is just education. In terms of, this is going to be one of the first immunotherapy drugs that is approved for breast cancer space, but we've been using immunotherapies in melanoma and lung cancer for years now. So there's this guy out of Harvard named Hal Bernstein. When this got FDA approved, he said, if when immunotherapy comes to breast cancer, all the doctors are now immunotherapists. And so we have to be aware of the toxicities are different than chemo, right? So when we're thinking chemo, you're thinking nausea, vomiting, I'm going to lose my hair, fatigue, diarrhea, and immunotherapy toxicities are very different. And people in the community, when you go see your primary care doctors, might not recognize those. So there needs to be an education for our community, and even not just medical oncologists, but our endocrinologists, our pulmonologists, your primary care doctors to say, hey, I'm not just on chemo, I'm on immunotherapy. So when if you go there and you have normal blood sugars and you go see your PCP and it says your blood sugar is 400, you have diabetes now. Well, maybe the immunotherapy took out or injured your pancreas, and now you need to be on insulin, and the therapy he's prescribing is not right. So we've seen this several times, and we're going to see it more, especially as this immunotherapy comes to our breast cancer patients. And there is a revolution of this immunotherapy that it needs to be education in the community and our community doctors, because you're seeing us, but most people probably have 2, 3, sometimes 4 other doctors they're seeing. And the toxicities we're seeing are not like chemo. So if you're fatigued all the time and you're saying, oh, well, it's just chemo fatigue. Well, maybe that's not true. Maybe you've developed low thyroid now. And so there are things that they need to be checking for, at least communicating with us, to say, hey, my patient's in the office and they're having this issue. What do you think about this? And I think sometimes I'm a stickler on proper nomenclature, and I don't call it chemotherapy. I call it immunotherapy, because it helps delineate that, hey, it's a different type of therapy and the mechanisms work differently, and the profile of toxicity is different.
Great. All right, just to go back on that patient, the reason why I brought her up, triple negative is very important when we look at stage 4 disease, but I did want to bring up one point just on the surgery side. So this was a woman that had breast cancer, only one part of her breast, and she actually had chemo first. The tumor had gotten much smaller. She still had the choice to do a lumpectomy and ask her for her lymph nodes to be removed. The reason why I bring that up, because a lot of women think that if you have bilateral mastectomies, you're cured. You have no risk of the disease coming back, and that's absolutely an untrue statement. So if you have the opportunity to preserve your breasts, or if you need a unilateral mastectomy, in most cases, it will not change your outcome if you choose a lesser invasive procedure. As well, when she had chemo initially, and then she had surgery, and she had residual tumor noted, that's another risk factor for her to have recurrence to come back. So as providers, we were not totally shocked, because she had advanced stage disease on presentation. When she had chemo, the tumor was not totally resolved. And when it's totally resolved, that's what we call a pathological complete response, just for you to be familiar with the verbiage there.
Dr. Johnson, can I make one more comment about this case? So there are some misunderstandings out there about what choice you're really making when you choose a mastectomy or a double mastectomy, and I'm really glad Dr. Johnson brought that up. One of the misconceptions out there is, in a case like this, if I have a double mastectomy or even a single mastectomy, I'll avoid radiation therapy. Absolutely not true in this case. This is advanced disease, triple negative with residual disease after neoadjuvant chemo. This is a radiation patient every single day. So we really want our breast patients to meet with their radiation oncologist early in the process, because they can explain when they would and would not need radiation. One of the things we have a hard time with in the community is a radiation doctor in the community often doesn't want to see a patient unless they're sure that the patient's going to need radiation. And we need to push back on that. You need a consultation with all of your specialists, whether or not it's clear you'll need their services, simply because a multidisciplinary approach requires all the expertise at the table.
Great. All right, we'll move on to our next case. She's 58 years old. She presented with a breast mass in the left breast. She actually had her first mammogram at 58, which we know is not good. Most common type of breast cancer as well, invasive ductal carcinoma. She's estrogen positive as well, progesterone positive, and HER2 new positive. So that's what we call triple positive breast cancer. She had a family history of a great aunt with melanoma. The breast itself, she had a 3-centimeter mass. Her lymph nodes were at least 2 centimeters in size and fixed. So the doctors did what we call a metastatic workup. She had a lesion in one lobe of the liver. Both areas were less than 2 centimeters in size. And we're going to start talking about the chemotherapy regimen that would be recommended and possible clinical trials and move on.
I guess I get to go first. So I haven't seen that. She hadn't had surgery yet, right?
No. De novo.
Yeah. So this is one of those kind of oligometastatic cases again, where there's kind of these isolated liver lesions. And so I think for this case, again, yes, this is stage 4 disease. This is devastating. Can I cure the patient? When we say cure, is there a way to get rid of all the tumor and not leave anything behind? I think this case is yes, but this person needs treatment. The kind of way to do this is you can kind of take a neoadjuvant approach. So there's a lot of different ways to do this. I think giving her a combination of Taxotere, carboplatin, Herceptin, and Perjeta up front. So that is IV so that's kind of 2 different chemo drugs and then 2 different anti-HER2 drugs. Assess for a response, and then you could take that patient for surgical resection. Afterwards, then you need and again, up front, you need a multidisciplinary approach because I need my surgeon on board and I need my radiation doctor on board because the chemo is not going to cure this person. The chemo will shrink the tumor. It'll make it go away. I may even make it not detectable on scans, but unless you can either cut it out or burn it out, that person's going to have a relapse. So I need buy-in from these two, and we're going to hear from them in a second about getting it out afterwards. Once that is finished, if there's any residual tumor, and maybe we can kind of come back and circle back and we'll talk about this, is what do you do afterwards? Because typically for HER2 positive disease, you need anti-HER2 therapy to complete 1 year total of therapy, and she's going to need an anti-estrogen because of the ERPR positivity. So once she gets through chemo and surgery and radiation, we'll hear from our colleagues there, she still needs more stuff for a whole nother year.
You want to talk about? Yeah, do Olga, then I'll talk about surgery.
Okay, so there's a little bit of uncertainty here based on response, but let me just generally speak to.
Scans are negative after chemo.
So in some centers, because the chemotherapists are so outstanding at their job, keeping track of the liver lesion is going to be a little bit of a trick because if you didn't put anything there, you don't know where it is anymore. And image fusion with pre and post therapy is tricky. It's not as accurate as, say, putting a fiducial in or marking the tumor somehow. The reality is that if you're talking about post upfront, or we call neoadjuvant chemotherapy, or post-surgical radiation in the adjuvant setting, we're fighting an invisible disease, right? So a woman has a lumpectomy or a mastectomy, and there's a statistical risk. Technically, that patient is no evidence of disease, but the radiation doctor doesn't believe it because we're professional pessimists, and so we treat the area despite there being no detectable disease. In this case, you have a patient who presented oligometastatic, and there is a little bit of question right now in the radiation oncology literature, how do we help them most? Because if the lesions disappear, you can't really do, we talked about the difference a little while ago about ablative versus radiotherapy. Am I destroying the target, or am I scrubbing and cleansing the target? This woman can have the area of the breast or chest wall cleansed by fractionated radiation, but if the targets have disappeared, you cannot ablate a target you can't define. You can't destroy the entire contents of a volume you can't draw. So in a very good way, the radiation doctor may have been booted out of this case in terms of the metastatic disease, and that's good. We're fine with that. And in a complete response. In an incomplete response, then we would be back in that oligometastatic setting, and we'd probably go to tumor board and come up with a way to treat this. The last thing I'd like to say about this case is let's pretend the liver lesion was there and we wanted it out. Although it is true that the first prospective randomized trial was using a technology from my department, that doesn't mean you can't extrapolate from the data. There is a real role for surgical oncology to address liver metastases. There's an absolute real role for interventional radiology. So we don't want to get caught up too much in this. For your radiation oncologist to address a liver lesion, they're often going to want a fiducial marker placed. But if the interventional radiologist is sitting with a needle in the middle of the lesion, it's pretty easy to use energy at that time to destroy that lesion. Why go through the extra effort of having radiation afterwards? So these are the things that you work out in a multidisciplinary tumor board. And I'm sorry I couldn't give more specific advice, but again, the response kind of boots me out for a minute. Yeah.
Okay. So Dr. French brought up the role of surgery in stage 4 disease. So in most cases, there is a questionable benefit, but the data is changing. So at our facility, patients who present with stage 4 disease, the best patients who do well are patients that have bone metastasis 5 or less sites. It's changing now for HER2 positive patients. The reason being is because once you get that treatment, a lot of times when we go to surgery, particularly if they're not stage 4, we see very little disease there. So there's some current literature out now. Say, for instance, this is that particular patient with liver metastasis. The study is not all the way conclusive, but I will tell you there are some patients who would offer her surgical intervention. The latest literature, based on what I know, is about 27% increase in survival. And so she would be given that choice. And I would tell you, when I talk to patients and they have stage 4 disease, a lot of them want it out because their goal is to get this out. But what I tell them is that in some cases, we can't get that out, what's already spread. The best treatment for stage 4 patients is usually what we call systemic treatment, radiation therapy. So in some cases, we would offer it to them, but like I said, we would present this case in tumor board and see how she did after chemotherapy.
I agree. I also just want to reiterate, these are challenging cases in women who have metastatic disease, and I do think that it requires an upfront multidisciplinary discussion. The only reason why we're able to even offer potentially a multidisciplinary approach is because we do have very good now systemic agents that offer prolonged survival in these women, even with oligometastatic disease. But I do think that these are case-by-case discussions, and unfortunately, it doesn't apply to every woman. And so in some women, we do solely offer systemic therapy with actually very good survival and very good quality of life and control of their symptoms related to their breast cancer. And in other women, we may offer a more aggressive approach with a combination of surgery, radiation, and systemic therapy.
So she did have surgery in this patient, so this is going to be quick for the medical oncologist. So she had residual tumor, 1.5 centimeters, 4 out of 18 positive lymph nodes. What would you offer at this point?
So for this woman, we have gone with a more aggressive approach with upfront neoadjuvant chemotherapy with a very good response of her cancer, and then the woman has gone for surgical resection at this point. So now we're at a point where we have no evidence of disease in the woman, but we still are looking for treatment to prevent the recurrence of her breast cancer in the future. There is actually some newer data that just came out in December of 2018 that utilizes a new drug called Kadcyla, which was previously used only in the metastatic setting for HER2 positive disease. We're now looking to use that in women who have residual HER2 positive breast cancer at the time of their breast surgery. And that has actually offered an improvement in both invasive breast cancer survival. And shortly, I think we will get some survival data on this as well that will show overall survival benefit. Kadcyla is given similarly to Herceptin, which was used previously in these women, IV every 3 weeks. So the options that we would have would be Kadcyla IV every 3 weeks to complete a full year of HER2-directed therapy versus Herceptin with or without Perjeta to complete a full year of therapy. For this woman, given the aggressive nature of her disease with liver metastases, I would offer her Kadcyla, although she does not perfectly fit the patients that were studied in the Catherine trial for Kadcyla. I would still offer her Kadcyla given the improvement that we've seen in invasive breast cancer recurrence with the use of that drug.
Yeah, I would agree with that. I think if you look at the Catherine data that was published in the New England Journal of Medicine, the hazard ratio is like 50%. So that basically means there's a 50% reduction in someone's invasive disease-free survival, or invasive disease-free survival from their breast cancer. So you can take someone who's 77% and bump them up to 88% chance that maybe those people are cured. You're extrapolating that data because this person had a liver lesion. So you're kind of extrapolating that data to say, yes, this drug works better if there is residual tumor left behind. If the person had a pathologic complete response, meaning that at the time of surgery, yes, we know where we mark those tumors, we cut them out, and there's just scar tissue, it might be reasonable to continue the Herceptin or even just the Herceptin Perjeta and not switch the drug. But because there was a little bit of tumor left behind, with this new data that came out in December, we would probably switch her. She also has one other option, which is after, now we're oncologists, so we keep doing things to patients, right? Is after she finishes that anti-HER2 therapy, she does have the option to take a pill, which is called neratinib, which is an anti-HER2 directed pill. Again, this is being extrapolated from adjuvant therapy, meaning these are not stage 4 patients, but there was an invasive disease survival increase by about 2% if you add this pill for another year after you've already done the year of anti-HER2 therapies. Now we're talking after surgical resection, 2 more years, one of IV and one of pills, to add to this woman for about maybe a 2 to 4% benefit. This is a little tough because on the pill, I don't think there's a lot of people that are prescribing this for a 2% benefit. Now, obviously, if it's stage 4 and you're trying to cure these people, maybe there's some data there, but you know, the cost is an issue. You want to talk about that, or
I
you?
just want to say one thing about that. Yeah, I totally agree, Dr. French, with what you're saying, and I do think it is worth a discussion to talk about the use of neratinib after Kadcyla. The one thing I will say about it is there are toxicities seen with the neratinib, the primary one being pretty severe diarrhea. And so if it does end up being a quality of life issue, I think at that point you do have to weigh the risks and the benefits of how much survival improvement do we get with what are we doing with the quality of life for our patient. The other thing I would also like to mention is that woman was triple positive, so we would add hormonal therapy in addition to any HER2-directed therapy that we would do after surgery. And so I do think that there is a chance potentially for what we call cure for this patient, although she would need very close follow-up, given still a higher risk of recurrence with the fact that she had liver metastases at the time of her diagnosis.
So she comes back now. She comes back a year later and just has some memory loss, just doesn't feel like herself. And so we did a metastatic workup, including brain MRI, and she does have a single foci. Dr. Cavanaugh, you want to address that?
Glad that we've moved on to a brain metastases because the post-mastectomy radiation question in this case is impossibly tough, and I don't have a study. Okay. So let's move on to the brain met. In this case, I believe we have a biopsy-confirmed lesion in the liver at presentation. Okay, right. So we have evidence of hematogenous spread, right? Cancer can spread 3 ways. It can invade what's next. Next to it, it can go through lymph nodes. It can go through the blood. This one already learned how to go through the blood. That's really important. Because if the brain lesion is the first presentation, you got a real trick on your hands. Do you blast away as if you know what you're doing, or do you require some proof? In this case, we can probably just go ahead and take care of the problem. So you would have a neurosurgery consult, and you'd have a radiation oncology consult, and you deserve both. And most patients, unless the neurosurgery is going to be very easy, it's a place that's going to induce very little deficit, most patients in this situation are going to lean towards stereotactic radiosurgery. And the reason is, if you have the lesion resected, you're still going to need radiation. And so why not just take care of it with a single shot of radiation? A lesion under 2 cm, what did we say the size was? I'm sorry.
In
the brain?
2 centimeters.
Okay, so your radiation doctor is probably going to be on the fence between a single shot and a few shots, but that should be a lesion they should be able to control fairly readily. Under no circumstances in 2019 would a woman in that situation receive whole brain radiotherapy, because we would want to treat again. We're not going to use radiotherapy, which is scrubbing something clean with repeated daily treatments. We're going to use radioablation or radiosurgery, which is let's destroy the target in a very, very thin rind around the target. In this case, your margin on the target would be about 1.5 millimeters. So if you can imagine that, it's a very, very, very tight situation. You're just destroying everything inside because there's no functional brain tissue in there. That's all disease. And so that's how that would be managed. From that point onward, your radiation oncologist is likely to be your brain manager going forward. So yes, you're going to see your medical oncologist just as much. We're not taking anything away from them, but the rad onc would be expected to continue to follow indefinitely. And we actually aren't able to tell you right now what the survival data are for repeated SRS, SRT as we call it, in situations like this because they're changing so rapidly. I have many patients who have had a half a dozen or more stereotactic interventions in the brain over several years. And if you'd have told me that 15 or 20 years ago when I was a resident, I would have laughed because those patients don't live long enough for that. But they do now. And we can get control in the brain and maintain control for quite some time. My last comment would be radiation oncologists are qualified to tell you if you can't have any more radiation. And even they often have to build a 3D model and put an hour of work in before they can give you a yes or no. Nobody should be telling you you can't have radiation if it's not what they do. Your radiation doctor better not be telling you whether you're an immunotherapy candidate either, right? It's really important in this arena of changing data that we stay in our lanes and respect our colleagues' expertise.
All right. Any quick questions?
Could I comment about genetics for her?
Yeah.
Okay. Briefly, so this patient would not meet current criteria for genetics based on the type of breast cancer she had, so it was not triple negative. Her age would not be considered early onset, and her family history is not suggestive. However, number one, family histories can change. So if your family history was taken at your initial diagnosis and no one has asked you, are there any new diagnoses of cancer, that's not great. Please proactively update your providers, because it's not just, do you have breast cancer in your family anymore? It is, do you have pancreatic? Has anyone died of prostate cancer? So there's lots of different types of cancer that are part of the guidelines that could be in a family history that would make a person a good candidate for genetic testing. And number two, the only other way that this woman could possibly be a good candidate for genetics is if her tumor test, if she had a tumor test at some point, and a BRCA mutation was identified in her tumor, they're always supposed to be offered testing to see if it could be something that was inherited, even if they don't meet any other criteria for genetic testing. So the genetics question is kind of never off the table because these things can evolve over time.
Any questions?
So we talked about stereotactic radiation for metastatic breast cancer, right? What's the latest on the use of proton therapy?
So for those of you who don't know, proton therapy is a particle therapy. There's three types of dose laid down when a radiation target is irradiated. There's entrance dose, which is undesirable. There's target dose, which is desirable. And there's exit dose, which is undesirable. Protons have entrance dose, undesirable. They have target dose, desirable. They do not have exit dose. So in those situations where your exit dose is limiting your ability to treat, there's an advantage for protons. There is not a cancer cell killing advantage for protons. There is not an advantage in killing cancer cells with protons. There's an advantage in exit dose. And sometimes that advantage is critical to accepting the case versus rejecting the case. So most radiation oncologists today aren't going to need protons for the vast majority of cases. But before a radiation oncologist says they won't do a case because of prior dose or dose limitations, they should definitely reach out and talk to one of their proton center colleagues. It hasn't been a month since I've sent a patient. We're very grateful that we have a proton center in our community now with Emory. We have a great relationship with them. If I'm going to tell a patient, no, I can't, and the reason I'm going to say it is because of exit dose, they deserve an evaluation by a proton center. In terms of a higher kill rate or better control rate for brain metastases, that's not something we've seen in the literature.
Okay. We have actually a question from the Facebook. And so, yeah. And so we have a question, and she wants to know, can you discuss DCIS stage 0 to 1 and grade 3? So I will tell you, DCIS is stage 0 all day, every day. Grade is different than stage. Stage takes into consideration, and I'm going to not go into extreme detail in the stage, because stage just all changed. So stage takes in consideration how big the tumor is in your breast. It takes in consideration the lymph nodes involved, the number in particular. And then another part of stage is what we call metastatic part. So it's T, N, and M. And so stage 0 is DCIS. Stage 1 breast cancer is usually a tumor less than 2 centimeters. A lot of times it's more favorable, estrogen, progesterone positive, HER2 negative. But grade is just how fast the cells are growing. So grade 1 is always better. Grade 2 is kind of midway, and grade 3 is what we call a more rapidly producing cancer. And if you guys want to comment, let me look at the last question here.
They're going to pull the last question. I'm going to say
Oh, I can't see that. Sorry.
the one thing about when we were talking about this naratinib, and one of my pet peeves is drug cost, is there's a small little benefit. That drug is about if you were going to pay out of pocket, $12,000 a month. The annual cost is $125,000 a year for a 2% benefit. So if you kind of look at the number needed to treat on this, to kind of prevent, not survival, to prevent one invasive disease-free event, the annual cost to the total healthcare system is about $6.4 million. So I think as medical oncologists, and to the community here, and you guys are saying, well, we talked a lot of sciencey things and things that we're going to do and this, that, and the other, but at the end of the day, when patients are in my clinic, is it going to work and how much is it going to cost me? And so I just want to bring it up as food for thought, because this is coming down the pipeline in terms of, we're hearing it on national news, is that there are a lot of therapies and they're expensive, and people say, how do I pay for it? And drug companies are saying, don't worry, patient, you get a $10 copay. So you're paying $10 a month, but I guarantee you someone is paying $12,000 a month. And so even when we talk about adding Perjeta and these anti-HER2 therapies to prevent, one event, it may cost $13 million. So I bring it up just to say, when you're in our clinic and these are just questions that we get, these are issues that I don't have an answer to, but we need to be addressing those and at least talking about it in the community and thinking about it. Sorry.
We have one more question from Facebook, and I'm not sure if you're really going to be able to answer this, Katie. She's 54, breast cancer, didn't give the hormone receptor status or anything, and her mom has lung cancer, so she wants to know, should she have genetic testing?
Sure. So lung cancer is virtually never hereditary. So that in our world is not typically a red flag for genetics. So if there's no other family history of what we would say a BRCA-related cancer, so pancreatic, breast, ovarian, metastatic, or more aggressive prostate, and the patient is not triple negative, then, and there's nothing in the tumor as far as a BRCA mutation, then there does not seem to be an indication for genetic testing.
Okay, great. All right. Any questions? Oh, okay. Are we good on time? They'll get me, but let's go ahead.
Okay. You have, I won't yell. You have your surgery. Everything comes out, you're stage 2. Okay, lymph node negative, and you've had it removed. But when you get your first tumor marker back, you find it's quite high. And another month later, in other words, 3 months out from surgery, you're finding it's gone up. You go for a PET scan, you find out it has metastasized to your bones. Why wasn't a PET scan done right after surgery or at that time to see if, even though everything else has come out negative, it may have metastasized somewhere else? Is that a choice of the doctor? Is that because of insurance? What's the reason?
Yeah, so there's a couple things. One, it isn't an insurance thing, is that you could try to submit for a request, and if the patient's clinically asymptomatic, it probably won't be covered. So unless there is something that drives it in terms of that you had an elevated alkaline phosphatase or there was a lab abnormality that kind of, in addition to you having pain or something, saying I'm having back pain or I'm having hip pain, that is a clinical indication, that is a laboratory indication to say, yes, we should order a scan. But in the absence of any of that, for a stage 2 lymph node negative breast cancer, either prior to surgery or after surgery, A, would be denied by an insurance because they have their own guidelines and everything like that. 2, it's not supported by the NCCN guidelines, ASCO guidelines, or really any kind of comprehensive cancer network to say that this person needs imaging. The reason for that is the likelihood that you find something is rare. It's so low that you're not going to find anything. And so they say, well, if the test isn't going to, if your pre-test probability is so low, don't do it. The only thing you're going to do is either expose someone to radiation that they didn't need, or B, you're going to find some sort of incidental thing that we don't necessarily, wouldn't change what we would do anyways.
That's a tough question. It's a great question. I'd like to comment a little bit on imaging. First of all, it may feel emotionally like it would have benefited that patient to find those bone lesions. The possible benefit there is that they may have avoided a surgery they didn't need. There's no benefit there to the outcome of the disease or the case. So finding bone metastases 90 days earlier just isn't going to change the fact that they're there. That's one thing. We want to make sure we're speaking the same language as the patients. And the patients often think if something is found 30 days, 60 days earlier, it changes things, but it really doesn't much in this example. But the other thing I want to point out is look down at your pinky, at the final crease in your pinky. From there to the tip of your pinky is 1 billion with a B cells, right? So we're all mammals, so it's 1 billion cells per cubic centimeter. No form of human imaging can detect a millimeter by a millimeter by a millimeter. Not an MR, not a PET, certainly not a PET scan, not a CT scan. So the idea that a scan means something isn't there is just not correct. A scan means there isn't a lot of something there. So a negative PET scan means you don't have, let's say, 75 million cells all together in a clump, or we would have seen it. But you could have 5 million cells in 100 different places, all cancerous, and your PET scan's clean as a whistle. So we've got to be a little bit careful. Radiology is guesswork. It's high-tech guesswork, but it's guesswork, all right? Pathology is the truth, right? So we just want to be a little bit aware of the limitations of imaging, and also what would it benefit the patient to have learned that earlier? Not to mention all of the tremendously valid points that you made about false positives can harm the patients, etc. I'm always very clear with my patients when they use things like, my cancer hasn't spread, I'm cancer-free. Those are declarations of a proven negative, and we can't do that in science. You can't prove negatives. I have no evidence of disease. Now you're on. Now that's right. That's spot on, right? They can't find my disease. I hope the explanation is that it isn't there. Love it, right? We all agree the dodo bird is extinct. We haven't proven it, right? We haven't. You don't tell me you've proven it. You most certainly have not. But we all agree the only reasonable explanation, and we haven't seen one in 100 years, is that there aren't any. That's how cancer works, right? You're 2 years out, you're 5 years out, you're 10 years out. You haven't been proven to be cancer-free. We've proven that we haven't found it, and that's called no evidence of disease. So I just wanted to take this opportunity to clarify that because it's related to relying too much on imaging to tell us the truth.
Okay.
There was another question over there?
Yeah. Okay. One more.
A bunch.
And then the docs will be around maybe for a few minutes, okay? Go ahead.
Back to case number 2. I see that the patient was triple negative and had invasive carcinoma. So say, for example, that chemotherapy doesn't work for that particular patient, and they go through the Foundation 1 testing and they can't find anything that works for that patient. Right. What would be the next step?
So I think that the next step would be to either offer a standard of care chemotherapy approach, which we know that triple negative breast cancers in general seem to be very chemotherapy sensitive. Again, a little bit dependent on what subtype of triple negative you end up having, or whichever patient ends up having. The second is to look for a clinical trial that perhaps is not directed against a particular tumor gene change, but rather a trial that's open to women who may not have actually a genetic change detected on their tumor. So the one trial that I mentioned, there are multiple trials like that who are looking at women with triple negative breast cancer with metastatic disease who have progressed on at least 1 to 2 lines of standard chemotherapy with no other approved agents to use. And we do have clinical trial options available, whether it's the combination of 2 drugs, maybe a combination of a standard chemotherapy with the newer targeted agent, or perhaps with a completely new first-in-human drug that is shown to have some efficacy against cancer.
Yeah, and I would also add that there are a lot of drug developments in the pipeline. I think there was a phase 2 looking at a drug called sacituzumab govitecan, which looked at triple negative patients greater than 2 lines of therapy, and you're seeing response rates like 30 to 40%. In the hormone positive patient, they also did a trial with the same drug, greater than 6 lines of therapy. The average woman had 6 or 7 different treatments before they got this drug, and are seeing response rates like 30, 40% shrinkage, which is kind of unheard of. So there are drugs coming. There are clinical trials that you can enroll on. I think most of us for triple negative are going to say, instead of just giving them standard of care and say, oh, here's some more chemo, let's find a trial for you. If you have something that let's get you to a referral center, let's get you to Emory, let's get you to me. we'll send patients to the moon for trials if we have to.
And if you do look online, there are actually you'll find a lot of good resources, clinical trial numbers that you can even call. And a lot of our institutions do have a number for the clinical trials office where you could speak with someone and perhaps you could be pre-screened for a trial. And if you are eligible for one at either our institution or a different institution, then we'd be able to give you that information.
I just want to say one more thing about genetics, because I can't stop. There is a new recommendation in NCCN, which we've referred to as sort of like where all the guidelines come out of, that says any woman with HER2 negative metastatic breast cancer should be offered BRCA1 and 2 testing, not because they are highly likely to have something inherited, but because of some of these new therapies out there. So that's one of the first times, or I think the first time, NCCN is starting to recommend inherited testing purely for treatment purposes. And I think that's probably going to continue. So if people have been told, like I just told this person on Facebook, that they don't have a suggestive family history, but you have HER2 negative metastatic breast cancer, you should now definitely talk to your doctor about meeting with a genetic counselor or having genetic testing.
And I think you can correct me if I'm wrong, sometimes that testing is free.
It can be, or
Yeah.
that's why you should meet with a genetic counselor. We'll help you figure out all the billing stuff. Yeah.
All right, I enjoyed this. I hope you guys got a lot out of it. I want to thank Dr. Cavanaugh from Cancer Treatment Centers of America. I want to thank Katie Lang from Northside Hospital. I want to thank Dr. French from WellStar, and I want to thank Dr. Bhave from Emory, and I hope we can work together soon and do this again, okay? Thank you again.
It's now time for lunch, which is outside. Our next session is at 12:05, and that's clinical trials with Dr. Zelnak. So we'll meet you back in here. Thanks.